say welcome and welcome back to Jerry, who is usually the chair. I am chairing today because Jerry is returning from a period of recuperation, but I'll take the chair for this meeting again until Jerry's fully fighting fit, which I think he's not far away from. So welcome back, Jerry.
Thank you, Philip, and thank you for chairing today.
Not at all, not at all. So if we move to apologies, Stephen, have you got a record of apologies?
I do. There's apologies from Catriona Sinclair, Christopher Bowes, Jill Mitchell and Elaine Ward. And David Fraser and Tim Allison have noted that they'll have to leave by 3 o'clock.
Okay, thanks very much, folks. Just on on that, we've started an hour later than usual, and I'm aware that there was an earlier email that went round. That was just to fit in with the staff governance committee that was on this morning. So it's much appreciated for folks to make the time and space in their diaries for that later start. So moving on from apologies, we've got declarations of conflict or interest. Does anybody wish to make any declaration? I don't see anything there. I have had in the past problems with not seeing the hands, so perhaps Stephen, you can keep me right if there's something that arises that I'm just not seeing. I do see in the chat that we've also apologies from Fiona Malcolm and Simon Steer. Okay, and if we just move on to 1.3 on the agenda, which is the assurance report and the action plan. So we're looking for the board the members of the committee to approve the minutes of our previous meeting. Does anybody want to wish to raise any issues about the minute?
Can I come in here? Sorry, Chairman. Could I ask the chair if I have permission to read a communication that I've had from Michael? Are you happy for me to read this out? It's about something in the minutes.
I've got no objection to that.
It's just he just wanted well, first of all, he says you may remember at the HSCC meeting of March 15th, I raised the issue of the North Coast redesign, an issue I've raised over the past few months. Pam Kremen, ICO, apologised for not inviting me to a cross-check event, and I was offered a meeting which subsequently hasn't happened. As at the April 26th meeting, Pam Kremen offered to arrange another meeting. The head of primary care offered to attend this meeting. When arranged, this meeting has not taken place. It may be because I'm no longer on the committee. However, after being on the committee for 6 years, some courtesy may have been warranted. Having attended the Framework for Engagement SLWD since 21, I think I may have expected better, a case where the respond well box cannot be ticked. This raises the question of lay members, their places and role on the committee. After years of deflection, apologies, etc., it's become a wee bit tiresome. I'd be more than happy to attend a meeting, discuss these matters if required. And finally, I haven't received an official letter acknowledging my services on the HSCC committee 2 months on from my last meeting. You may like to present this to the committee under matters arising. Regards, Michael.
Okay, thank you for that, Michelle. And I'll certainly pick up the issue with a letter. It had been my intention to write a letter to Michael. I took on that responsibility in the absence of Jerry, and that's entirely my fault that hasn't proceeded. So I will write that letter to Michael, and I apologise on the committee's behalf for not doing that. If you want to convey that to him prior to receiving the letter. In terms of any meetings with Pam, and she can respond if she wishes, but I certainly know that Pam had been trying to arrange meetings with Michael, and as a committee we were sorry that those meetings didn't manage to take place, but that wasn't through any disrespect. That was just through either pressure of work or diaries not fitting together. So I'll make that apology on behalf of Pam. If she wants to respond on as well, then she can. But as an apology from the committee, then that's that's my response to that. And
Sorry. Yeah, just to add that there was a letter also from Jerry, and has gone out in the post, so it should be with him. So,
I'll pass that on. Thank you very much.
Okay, thanks, Michelle. So are there any other issues that anybody wants to raise with regard to the previous minute?
Hi, I'm down under my day job, but I think I'm here under as a staff side representative. So I'm down as a daycare officer, which I am on some days, but I'm down here. I'm here as a staff side representative.
Okay, so if we can have the minute reflect that. Anne.
So just a typo issue, but as it's about assurance, I guess it's quite important, Philip. Item 3.5, I think the text says that on the one hand, assurance was moderate, and on the other hand, it was substantial. So there's just a little something to tidy up there.
That's fine. Stephen, could you take care of reflecting what the correct level of assurance was there? So I suppose it needs to reflect the recommended level and what was actually provided. Okay, folks, if there are no further points on the previous minute, we'll move on to matters arising. I have got one recorded matter arising, which is the Integrated Children's Report, where the interim 6-month update is on the rolling action, that's the action plan, and it's due for the September committee. Are there any other matters arising that anybody wishes to pick up? Jerry.
Thank you, Philip. Just to let committee members know that I've spoken to the chair of the Clinical Governance Committee and the chair of the Audit Committee in relation to care governance, and Pam and I are going to pick it up on Friday, and I'm confident that we're going to have a proposal coming to whether it's this committee or whether it's some other governance route through the board. We should be able to move that forward, so we should be able to give a further update at the next committee meeting. But it's important, I think, to record in the minute that the chairs of the Clinical Governance Committee and the chairs of the Audit Committee are aware of the concern that we raised as a committee in our annual report. Thank you, Phil.
Thanks for that update, Jerry. That's useful. And if there are no further issues to raise, we'll move on to the next section, which is finance. And as you'll all be aware, unfortunately, we haven't received the financial report, and owing to sickness, the sickness of Elaine Ward, we were hoping to get a verbal update. That's also going to be unavailable for today. Hilleth Cooper, the Director of Finance, has stated that we will be provided with an update following this meeting. But unfortunately for today's meeting, we have neither the written report nor the verbal update. It's a bit unfortunate, or more than a bit unfortunate, as we didn't have a report for the last meeting. So I think as far as the minutes concerned, we need to record that we have had no update for this meeting or for previous meeting. Is everybody satisfied with that as an action, or Anne?
Thanks, Philip. So I think that perhaps, well, I'd like to suggest, and acknowledging that there may be special circumstances associated with not getting a report for 2 meetings running, but I think that's quite a significant matter for the committee, and I'd like to suggest that it should be drawn to the attention of the board when we're discussing the minutes of this committee at our meeting in July. Thanks.
Yes, we will bring that to the board's attention, whether it's myself or Jerry who provides the update. Any further comment from any other committee members? No, okay, if we move on to our further reports, and at 3.1 we have a care at home assurance report from Gillian Grant. Gillian, do you want to make comment?
Philip, if I may, I think I'll present the report just in terms of having the lead responsibility for the short, medium and longer term actions that we're going to take. So I'll start off, and obviously with support from Gillian, who if we need to clarify around the data and weight, then we can do that when we take questions, if that's acceptable.
Well, thanks very much, Pam.
Okay, so this report is provided to the Committee for Awareness of the proposed areas of activity and to assure about the steps that we're taking to address the current and forecasted challenges that we have in terms of care at home service. We know and we have presented in terms of the background there, the costs, but more importantly, people who are waiting in hospital or waiting at home for care at home services. So definitely deficits in those care areas that we want to improve. So in terms of recent issues then in terms of workforce and stability and providers' ability to manage their contracts. We need to achieve a stable, resilient and assured provision going forward, and we also need to grow staff and grow services in order to respond to continuing increasing demands. We have had a number of contracts handed back to us from providers, and they've verbalised to us and obviously provided the evidence around high attrition of staff and unsuccessful recruitment. And staff wellbeing issues and staff experience issues within the sector. And of course, we're well understood about the geographic challenges in the remote and rural delivery and the additional costs to staff and organisations in terms of providing that care in people's homes. So over the course of 22 to 23, there's been a significant reduction in available commission services, 1,430 hours per week. Despite good relationships with providers, despite them escalating issues early so that we can work jointly on solutions, it's been a really, really difficult space to be in. And that's resulted in waits for people as our care home services reduce their capacity. So what we've done is we've made an assessment which is outlined in the paper, and we are planning a robust programme of work, which is a standalone programme of work around care at home, but is also an integrated programme of work around, supporting people who have delayed discharge, to improving flow within the hospitals where people are waiting, that is impacting on elective care, and also where we're delivering new and innovative ways of working to grow our own workforce, and delivering against the urgent and unscheduled care programmes around delivering care closer to home and in people's home and wrapping services around them, and trying to plan for care at home services and care at home workforce to be more part of multidisciplinary teams. So we have developed a programme which is articulated in the document for the future delivery of care at home services to sustain the service. So we want to maximise provision through processes, training and technology. We want to enable the market to deliver stably and create sustainability for them. We want to create and sustain and grow capacity. We want to recognise value and promote the paid carer workforce, and we want to improve affordability, so that we can attract care at home providers. So there's a number of short-term actions being taken. So through our joint arrangements with the Highland Council, we are agreeing a vision and a project plan for care at home. And also in terms of understanding the risks of not having care at home services in place, we are jointly developing a risk register between NHS Highland and the Highland Council, and a monitoring framework around the mitigations that we're taking. We've been horizon scanning. We've been looking at what does success look like in the care home sector. So adult social care leaders and staff have been identifying areas within other integrated joint boards, and we're linking with the Scottish Government as well and other IGB chief officers, so that we're collectively nationally looking at this. This is not just an issue within NHS Highland. We are looking at redesigning our commissioning process so that we can underpin and develop some tests of change using our quality improvement methodology, the Plan, Do, Study, Act. So within contracts, making sure that we can test new ways of working, and that should give us longer term service delivery and sustainability with partners. And we want to maximise the benefits of self-directed support, and we've got a very detailed paper being presented to the committee later on. We have a number of complex financial arrangements which may be a risk to our cost avoidance plan. We've got a number of sustainability payments being added, when one of the plans that we had to minimise costs was to not have and not agree sustainability costs. But with the collapse of several independent care homes, and the need to place people, then we've had to revisit, and it's becoming quite complex to monitor and manage our cost reduction programme. We need to further develop performance measures. For the first time this year, our Health and Social Care Partnership Annual Performance Report will demonstrate outcomes against the National Health and Wellbeing outcomes, and that will be supported by a very robust narrative about people's experience of care and the outcomes for their care and the views of carers across the 9 health and wellbeing outcomes. And we're already doing proactive winter planning. So that's what we've that's where we're at the scoping and planning stage at the moment. In terms of moving forward to year 2 and 3, we're already in discussions in developing housing support models. So if we think about the Lochaber redesign and the Caithness and North Hubs redesign, we are well advanced in working with our housing partners on housing models, and that includes our digital health and care strategy partners as well. I mentioned earlier the urgent and unscheduled care programmes. We've done a lot of work in development. One of the key issues for us is that this is a very high level programme. It's prescribed by the government in terms of 8 high impact changes. So we've been working with NHS Tayside, who have managed to articulate these high impact changes in a way that's better understood and better aligned to more of their operational units. If we think of the waits for care at home or the waits for care homes, for people who are experiencing delayed discharge, then when we look at the Highline figures, we sometimes are not able to tell the story of the operational successes that we've had around the discharge support teams, responding to people's choice, being able to put people through the system very quickly. All of that kind of gets lost in the high figures. We've made significant progress on reduced length of hospital stay and flow, but what we must do is make sure that we develop systems in the community that are more upstream and prevention focused, so that people don't keep coming into hospital and require care and then require placement. So, as I say, the annual performance reporting going forward to years two and 3 will become more iterative. We'll be able to see that those changes more ably as we look across the "you said we did" kind of response. So if we're saying this year this is what we're delivering as an annual performance report against the National Health and Wellbeing outcomes, next year we'll be able to show how they may have shaped and changed and where we've made good progress or where we've had successful interventions or tests have changed in terms of our strategies. And of course, all of this underpins the delivery of the Joint Strategic Plan, which has just been agreed by the Joint Monitoring Committee and as a draft document with which we are going out to participate, engage across the summer months. So key to this, though, is around the workforce, which is the key issue in terms of our capacity and delivery. So we are delivering at pace a learning or a care academy in partnership with Scottish Care. So that should really develop our workforce jointly. So not just workforce for NHS Highland and our community, it's developing workforce collectively for our partners as well. So that should create success and sustainability across the service. We need to make sure that we support whole system flow in a balanced system. So really being proactive about our winter plan this year is important, but we're actually dealing with seasonal pressures as we've seen the attrition of staff to the hospitality and tourism sector. We hear anecdotally of a lot of high wages being paid for cleaning jobs and seasonal jobs. So for example, a chef I heard being paid £25 an hour, cleaning staff being paid £22 an hour. So it only magnifies the difficult arena in which we're trying to recruit and retain staff. We've got a lot of work around workforce transitions from hospital to community. So around discharge to assess and prescribing of care at home from a people in place based perspective. So moving people out of hospital, moving staff with them to try and provide those assessments that people need so that they get home early and they can maintain all of their assets and be healthy and we can be proactive going forward. So our independent sector providers and sector representatives are critical partners in the design and co-development as our carers. So a lot of work to be done around engagement, with service users, their families, with unpaid carers, paid carers, etc. So there's a list provided there of all of the people, and there will be others that we will want to engage with to deliver on this. There are 3 kind of immediate priority areas. So transformational change in our commissioning process redesign is very early work, and we're working at pace on that. We're already doing tests of change and looking at how we can make sure that care at home staff, for example, become part of multidisciplinary teams and that they don't stand alone isolated from that whole team input, and that should provide a better experience in terms of people coming at different times going into homes to provide care. So it should improve the experience for the person receiving the care, and it should improve carers' experience as well around staff coming more jointly at particular times of the day. The independent sector workforce pay arrangements for 23-24, that's still not been agreed. And the in-year plan for workforce availability and flexibility for improved resilience and winter planning, which I've already mentioned. So the 3 key things that we need to have there early. We're offering with the paper moderate assurance, moderate in terms of the fact that we've got an outline, of the work. Some of the work's already underway, and particularly advanced around urgent and unscheduled care programmes, for example. So I think I'll stop there and invite any questions. And if people want clarification around any of the data in terms of the provision that we've lost and the cost, then Gillian would be happy to come in and clarify any of that. Thank you.
Thanks, Pam. It's a hugely challenging area of work and has been for quite some time. That's a very comprehensive update, and I'll just invite members to either provide any observations or questions that they wish to ask.
Stunned everyone into silence.
I was going to say there's a huge amount of information there. Jerry.
Thank you, Philip, and thank you, Pam. I think you're absolutely right, Philip. There's so much information in the paper, but actually so many challenges in the paper as well. And I think we've done well today in terms of, I think, how the agenda is structured. There's so many of these papers that are actually demonstrating the connectivity across the system, and we're dependent on so many things. Probably a couple of things I would just like to maybe ask Pam on, and maybe Gillian to get her views on. One's probably more a question, and one's maybe more a thought. I'd be interested to hear a bit more about collaborative commissioning and what track. I don't need to hear ultimate details, because obviously that'll involve some aspects of that, but just what our thought process might be. But what I was actually particularly interested in, and I'm looking at, apologies, I'm looking at my other screen. I'm looking at the 5 key objectives. I think it's on page 4 of 7 of the report. Recognise, value, promote the paid carer workforce. And I'm actually just wondering, how do we think we're going to be able to achieve that? Because I think we're all very familiar with, and certainly I've had discussions with Cara, and Anne and myself have had discussions with Cara. And actually, I think getting the care workforce, maybe if we took the carer out of it, but we actually took the care workforce, and I think it is correct to call them workforce, whether they're paid or whether they're unpaid. But actually, how do we promote them, actually, to get them to begin to believe that actually we're regarding them as equal partners? So probably a fairly transactional question there in relation to how might we take forward the test of change in collaborative commissioning, but probably more interested in probably the more conceptual, in terms of how do we begin to actually live that statement of valuing our care and carer workforce, Pam. Thank you.
Okay, thanks for that, Jerry. In terms of the collaborative commissioning, that is around embracing what Feely outlined in his report, and working collaboratively with the third sector, more about their sustainability. So rather than going out to the market and us kind of interpreting what we think what we need for our services, is about coming together around that co-production and making sure that if we put in place as tests of change that we jointly work on to develop and deliver, then we can collaborate on a longer term basis, having underpinned that test of change, and develop some outcomes for going forward, so we can extend contracts as opposed to going out to the market, and that would create better partnership working, better sustainability, and that's actually better for our workforce in terms of their experience as well, because they're not faced with short-term contracts and perhaps having to find new employers at the end of periods. So this is all about collaboration and sustainability going forward. In terms of the paid carer workforce, I think James will talk a lot about that in terms of his SDS paper coming up. So there'll be an opportunity to hear about how we're embracing that and hear about the positive outcomes that there will be for carers, and the positive opportunities that there will be from delivering on our SDS strategy. And I'll pause there and I'll let Gillian come in, maybe around the 5 key objectives and the other points. Thank you, Gillian.
Okay, thanks, Pam. Thank you, Chair. So I want to come in on both points, actually, just to give a bit more detail to Pam's response, just from a kind of practical perspective. So on the commissioning approach and the collaborative approach, what we're doing with independent sector providers at the moment is we have a short life working group looking at exactly that matter. In fact, this time yesterday we were talking about it. And actually we're trying to get behind the language and behind the terminology to figure out what do we mean, because actually it doesn't really matter what we call it, it's about what we're doing on the ground. So what we're trying to do is to look back at, strip it back to basics. So how do we commission care at home? What does it look like? What should it look like? Both from a kind of macro, how we manage the market point of view, but also how providers individually work with each other. And I guess where we're trying to get to is that working more effectively on the ground, where you've got a neighbourhood or a zone or a geographical space where you've got providers who are working together to manage packages. So it might well be that on the ground, one provider can do bits of the service, another provider can do another bit. So trying to encourage and promoting that kind of collaboration on the ground is exactly where we're trying to get to. So that's in the collaborative side of things. Also within that short life working group, absolutely key area is about workforce. So how do we keep them? How do we get them? Are really the two key areas. And fundamental to that is about how we value them. So we are looking at really practical things that I think many of us take for granted about, if you're a carer on the road, where do you go to the bathroom? Where do you keep your sandwich? Where do you go for some downtime? Some of those things people take for granted, but actually if you're a carer going from visit to visit when you're very time aware, so we're trying to look at all those different really practical things where that will be hopefully helpful in valuing staff. I think there's a whole different area of work that's needed around how we perceive them with parity, how we perceive that sector with parity. And there's no one person around the table that can achieve that. I think it's everyone working towards a kind of concerted campaign, but certainly that's the aspirations in the short life working group that I'm chairing. So hopefully that's answered your question, Jenny.
Thanks, Gillian.
Thanks for that, Gillian. And we've got a couple more hands up. First is Kate and then Anne.
Hi, I was just wanting to say that I'm often supporting members of staff, who want to work, but perhaps with a change in circumstances, and on the West Coast, the local nurseries closed down, and if they or perhaps they've been employed to work from 7 o'clock in the morning and their partner's got a different job and can't look after the kids from 7 till school time. And it's about, I think that there needs to be sort of more flexibility within that. I'm often supporting existing staff who are desperate to get back to work, are desperate to do their shift, enjoy their job, value what they're doing, but just because of where they live, lack of childcare, one thing and another, they're having difficulty fulfilling that role,
I could come in on that. We have our reservist programme, so that's been a really, really good programme. It's worked really well for people who don't want to be tied to set hours, to set ways of working. They want to be responsive to any carers' responsibilities that they have. Some of them have partners who may work long stretches of days and then have a few days off, and they want to improve their work-life balance by not working on those days, etc. Obviously to manage childcare. So we do have a programme, and perhaps we need to think about and align when there are closures of businesses across sectors, then we should be more proactive then and going in and advertising our reservist programme, because we did have a launch, we did have success. I think we got about 75, maybe 80 people, Danellen, if that's right, so round about there. So that's a good lot of people to come and work all of these different hours, and a lot of them are working unsocial hours, which is really good as well. you know, in periods of time scales that might not be popular. So maybe we need to think about refreshing that and keeping an ongoing programme of advertising and trying to seek people in and offering that work-life balance and offering that flexible ways of working as well. Thanks, Kate.
Thanks, Pam, for that. Anne?
So I see Donellan's got her hand up. I just wonder if that's on what Pam's been talking about, because my points are on quite a different aspect of the paper. So I would just wonder if Donellan's wanting to come in on that particular point before moving on to me, Philip.
Okay, Donellan?
Thank you very much, Chair. Yes, it was just to add to that. So the Reserves Initiative has been really positive, and in addition to sort of the flexibility that Pam's described, we've got a number of people who weren't sure about entering the care sector, and they just wanted to dip their toe in the water. And since we started a few months ago, 3 people out of the 73 that we've recruited have actually come on to permanent contracts as well. So they've had a taste. And they've liked what they've experienced. So just for a wee bit of a flesh on that, we've had 62.5 hours being supported within hospital settings. So we've been supporting across a number of different settings. Within the hospital, it's primarily people who require additional one-to-one. So it's not healthcare, it's social care, but quite often actually people that are delayed, but they might be admitted into acute for particular health reasons, but they need that one-to-one support. We've supported 165 hours to our colleagues in the independent sector, and we've delivered 753 support hours to in-house. So it's just to give an indication. And we could actually recruit the same again. We do actually have a bit of an infrastructure issue because we weren't expecting the level of response that we've had. So it's just Kay's point about flexibility, and you know, being our approach has been, are you interested? What could you offer us rather than going out with, you know, here's a 15-hour contract sort of thing. So really interesting times for us, and we will look at whatever ways we can to try and attract people and keep them.
Yeah, that sounds quite optimistic if we're attracting people on that flexibility. And I think getting the actual practical perspective from Gillian and Kay about the barriers that we have and knowing them can assist in bringing them or putting them to the side. So no, some really good work going on there. Anne, did you still want to come in?
Yeah, thanks, Philip. So a couple of what I would hope are more straightforward questions and requests, and then one that's, I have to confess, a bit more challenging, probably. Oh, come on, Pam, you're well capable of dealing with my challenges, I'm sure. So the straightforward ones first. I just wondered the 5 key objectives. I'd like to suggest that, I mean, you know, I'm sure it's obviously implicit in your programme, but I think probably it would be useful to have explicit the first objective being around improving the outcomes for our, you know, for the people using our services, or fulfilling the objectives of our strategic plan, or however you like to phase it. But I think, you know, making sure that all of that very necessary work is, you know, is directed towards what's our ultimate aim would be really helpful. So I want just what people think of that suggestion. And the other thing from a care for you perspective, acknowledging our capacity issues, I wondered if I could get assurance that the visioning and the engagement side of this will, as far as possible, be integrated with the work that will be going on over the summer on the strategic plan, I suppose, I'm sort of conscious of the huge programme of work that's laid out here. And so, for me, I would hope that we're trying to integrate those two processes to, to not make life more difficult for people. So those are the easy ones. The harder one, I would imagine. I suppose I'm a bit challenged by the moderate assurance from two perspectives, primarily picking up on Pam's comments, my awareness of the scale of the challenge that we face from a workforce perspective because of the competition from other sectors, because of the pay levels that we are able to afford to offer to people, and the sheer shortage of workforce across all sectors in Highland at the moment. But also, and what would help me, the paper does refer to previous actions and interventions not having had the intended impact or desired outcome. So it would be helpful in considering that moderate assurance if somebody could say a little bit about the learning that we've taken from our assessment, that those actions haven't been as impactful as we would have hoped, and how this current set of actions has been adapted in the light of that learning. Thanks.
Okay, so I guess on the first point around the improving the outcomes for people using our services, yes, definitely. I think that's implicit because I had been explicit about the annual report and the joint strategy and how we wanted to develop that iterative process so that we could absolutely show where we were making progress against the National Health and Wellbeing outcomes, and that they aren't just a standalone once a year report without any iterative or any kind of analysis or intervention from our point. In terms of the the capacity issues for carers and all sorts of people needing to engage. We have already done a lot of engagement and learning through, we talked last time about the mental health and learning disability strategy, the Together We Care strategy. We know what people have been telling us, and we have taken existing feedback from what we've already done. So the existing feedback networks will be utilised to avoid engagement failure. So where community council meetings or community planning partnerships, or where third sector organisations are having meetings, then we will come alongside and try and utilise as much as we can the time and the space that people are already meeting in, so that we don't overburden them and that we don't get them to have that engagement fatigue. We've already picked up in our communities that people are a bit confused around Together We Care, and now we have a joint strategy, and they're wondering why we have two strategies. So in terms of what may not have worked so far in terms of our commissioning approach, for example, I will bring Gillian in, but underpinning that is, I guess, the experience that we've had of the collapse of the independent care sector, where we weren't aware, we didn't have that on our horizon scan, we didn't know that was coming, we didn't know that providers were going to pull out, although we entered into a time when we were meeting with them because they were struggling with their sustainability. So some of our interventions haven't worked because of our reactivity in terms of the issues that we've had to deal with as a sector. So can I hand over to Gillian to give a frame about our commissioning approach and the issues that may not have worked so far there. Thank you, Gillian.
Thank you, Pam. Thanks, Chair. So the interventions that we were talking about in the paper for care at home, so what that relates to is us following the UK HCA, so that's the United Kingdom Home Care Association tariff rate. So we've consistently used that in Highland for the past 5 or so years. Obviously, that's the kind of industry level, so we had anticipated that that would be an appropriate level adapted in Highland for urban, rural and remote. So we had thought that that would be effective. We'd also thought that the way that we're contracting and that we have baseline activity, so in effect, pretty much a block contract, and we had thought that those two, I guess, levers would be sufficient for being able to attract, retain staff, etc. That's not the case. That's not bold enough, I don't think. And in terms of the staffing issues across not just care at home but everywhere else, we need to look at different mechanisms to enable providers to recruit staff on a shift basis, and so that we're paying for shifts, not for individual blocks of time. So to move away from time and task, so that we're looking at things from far more outcomes focused. So the work that I referred to earlier, it is exactly that. So those previous interventions, if you like, or mechanisms, we don't think went far enough. And now what we're looking to do is just to make sure that the commissioning approach, both on a provider but individual service user basis, is as effective and efficient as it can be. And what we're very aware of is that we might need to review many of the contract conditions to make sure that that takes us to the place that we need to get to. And having reviewed the care at home contract recently, which I personally wrote about 8 years ago, it's from a different era, and absolutely needs to be refreshed and needs to be able to give carers autonomy and flexibility about what they need to do on the ground without having the significant level of scrutiny that we currently give. Absolutely, there will need to be scrutiny. There will need to be a level of assurance about what outcomes we're receiving. But I think moving away from the burdensome approach that we have just now is where we need to get to. So hopefully that provides some assurance.
Thanks both Pam and Gillian. I think that provides us with a clearer picture perhaps. And I think, Anne, does that answer the issues that you raised, certainly in the first two parts? In terms of the moderate assurance that's been mentioned by Pam, in terms of the assurance that's been requested on the agenda and in the paper, it started as substantial, so that's moved to moderate now. Would that be correct?
Yes, so that there was an original paper where we did seek substantial assurance. I reduced that to moderate, and that's where I outlined the sort of immediate actions and then the longer term actions for 2 to 3 years. So where I was coming from was that, whilst we don't have a lot of these issues in place, it was about assuring the committee that we have got robust plans, that there are a number of work streams, particularly around urgent and unscheduled care, a lot of work that adult social care is leading on in terms of discharge without delay, discharge to assess, working in partnership with other organisations, learning what good looks like, all of the issues that I went through in terms of the plans that we're going to take forward. So for the committee then, I think that the issue is, are they assured by the actions that we're taking and the things that we're going to try and do to mitigate against the position that we find ourselves within the care at home sector. So that's why the moderate assurance is offered and applied for the paper.
Thanks for that, Pam. I'm maybe working off an older copy. Anne, did you want to come back in?
Well, it was just to say, I think that, that having heard Gillian's explanation and also the work that Pam's outlined in her introduction, then, I'm happy to accept the moderate assurance proposal at the moment, and we will no doubt monitor during the course of the year whether it does have an impact through our IPQR, if nothing else. I think what would be useful perhaps would be if we could request an update on those 3 immediate actions, maybe in 6 months' time, or however, I'm not sure the detail, the timings behind those, but I'm sure Pam her team can decide when would be an appropriate point to bring back through the Chief Officer's report an update on, how those are progressing and what the initial view is about whether they're the right actions or not. So if we can agree that, then, on the basis of what we've heard today, I'm happy to accept the moderate assurance.
Pam, are you quite happy to bring back a further report in the near future covering these points?
Yes, absolutely. There is either a standalone report or as part of the Chief Officer report. What I would also add is that, by September we will publish the annual performance report, which is another mechanism that will provide assurance to the committee. And then we will also publish the joint strategic plan, which will be underpinned by the workforce plan, an implementation plan, a financial plan, a digital plan as well. So all of these forthcoming plans and ongoing updates should provide the assurance not only to the committee but also to the Joint Monitoring Committee.
Great, thanks so much for that, Pam. And if we can record that, Stephen, as an action, that will be helpful. And I'm conscious that I've kind of run well over time there. So can I ask the committee, are we happy to accept the moderate assurance that has been provided for this report? Yes, thumbs up. Thanks very much. Okay, if we can then move on to the next report we have, which again it's the annual report of Care Home Oversight Collaborative. And Pam, do you want to introduce that along with Gillian?
I think substantively I'll ask Gillian to introduce the paper. I'm going to go and just have a quick drink of water to clear my throat. So I'll just step out for a minute. Thank you, Chair. Thanks Gillian.
Thanks very much. Gillian, over to you.
Okay, thank you. So this report is now turning to care homes. So this is the Care Home Oversight Collaborative Assurance Report. So this report acknowledges the previous report to the last committee that you'll recall. There was a significant level of detail provided at that time, and that level of detail was about the sector fragility. So this report today provides an overview of the wider sector oversight during 22-23. It also describes a shift in emphasis as requested by the Scottish Government. So in moving on to the detail, there has been a care home oversight group in place since May 2020. That's mandated by the Health Secretary at the time, and that was to have a clear focus on clinical and care oversight. And there was an annual report to this committee last April, which set out the position at that time, having reviewed the last 12 months, but also with a bit of anticipation into the next year, which unfortunately many of those challenges have come to bear. So the detail just now in this report confirms that the Care Home Oversight Group has continued to oversee the activity. It's continued to meet fortnightly over 22-23, and has overseen a number of different activity areas, some of which are listed there. So on a fortnightly basis, that group has had a RAG status of every care home in Highland. There's been a focus on the red care homes in particular. There's been an oversight of the large-scale investigations and any suspension of admissions, viability, bed vacancies, etc. So that group has looked at all those issues at that frequency. And in presenting that today, we're anticipating that provides an assurance that there's been a clear oversight over that period. And Appendix 1 to this report also provides some headline information about some of the activity areas. So the number of operational and contractual meetings, care inspector feedback meetings that were attended, quality assurance visits, etc. And also to draw your attention to the supplier relief activity as well. So that's not just care home related, that spans across all adult social care. But since the pandemic, there's been 1,745 applications for supplier relief at a cost of just under £10 million, all of which have been met by the Scottish Government. So that's the first part I was wanting to flag, just about the care home oversight. Want to now move to the second part of the report, which relates to the shift in approach from Scottish Government and the request of partnerships to move away from oversight towards a collaborative support approach, with the intention of improving lives of people in care homes. So to do this in a collaborative way with the various aspects of the partnership interaction with the care homes, but also to do so in a collaborative way with the providers, residents, families and other stakeholders. So what we've had from Scottish Government is a resource allocation. So we've had in the Highland Partnership 681,000 made available to us. And that was on the basis of us putting in a submission to government, which went in May, about how that resource was going to be directed and targeted toward collaborative working to ultimately improve residents' lives in care homes. So for that, we submitted a Highland-wide response, including Argyll and Bute, and there's been a new additional paper as part of your pack that went out yesterday. I think that's referred to Appendix 5. So that's the appendix, that's information that we submitted as part of the bid. And Appendix 1 of that Appendix 5 is the Highland element. So that really sets out specifically what we are proposing to do with that resource allocation. Don't plan to go into significant detail on that. There's a lot of detail there. But I just wanted to flag that there's 3 different elements of that plan. And the first one is the collaborative care home support team. So we're now investing more money in the existing team to broaden the capacity and to broaden the scope. So that's now going to be widened out to include speech and language therapy, podiatry, physio, so that can be used as a drawdown resource from independent sector providers and in-house when needed. So that's going to have I'd say a larger, more responsive and more diverse group to be able to best support care homes, who in turn obviously will be improving outcomes for service users. The second element is about collaborative workforce solutions, and we've spoken quite a lot about that in committee already, and that's a sum of money we have asked to be set aside to specifically look at how we can retain staff, how we can use the resource that we all have between ourselves and the independent sector more collaboratively, and some initiatives used around that, for example, expanding the reservists that we've already spoken about. And then the third element is about collaborative sector support, so specifically around bed availability and how we can support beds to become available when they might not be currently due to either staffing or other reasons that they're not available. So looking to focus on those 3 areas as part of the direction of that funding resource. So that plan that you thought will be overseen by a collaborative care home group that will replace the previous care home oversight group, and that group will be responsible for making sure that that plan is achieved in the way that it's been set out. So because of that is the, I guess, intention of this paper, that's why we're offering a substantial assurance. So that is around the plan that we've prepared and the oversight arrangement that we have for achieving that plan. I'm happy to take any questions.
Thanks, Gillian. Yeah, it's very clear from the paper about the previous arrangements and the intentions now for the newer arrangements. Can I just invite the members of the committee if there are any questions or observations that they wish to pose to Gillian with regards to the paper. Louise.
Thanks, yes, and thank you, Gillian. One thing I just wanted to check out, and apologies if I've missed this because I didn't get to the last Care Home Collaborative. Have we had any follow-up correspondence from the Scottish Government for our plan? I'm not sure whether we're even anticipating any, but I haven't seen anything yet, so I just wanted to check whether they've come back to us.
I can answer that, Chair. No, Louise, there's been nothing has come back to my knowledge.
Okay, thanks. So I'm assuming that we're just going to say we're not waiting forever for a response from Scottish Government. We're just going to implement the plan that we've set out. That would be my view of the world, but I just wanted to sort of be clear on that one.
Yeah.
Gillian, did you want to add anything to that?
Yes, please, if I may. So I followed up personally with them this week, just to ask that very question, because I, like everyone, we're assuming that because we've had that allocation and that will just proceed. But for the avoidance of doubt, I just wanted them to come back. So I'm waiting for that, but we'll chase again next week if I've heard nothing.
Grand. Thanks, Gillian. Joanne.
Thank you. I just wondered if you could give a bit more detail about the Collaborative Care Home Strategic Group and the shift, you know, you're being asked to move with Scottish Government and how it's actually being received by the partners, and do you have buy-in from everybody or do we have gaps? Thank you.
I was going to ask who would take that, but Gillian.
Thank you, Chair. Certainly from our engagement with the independent sector, this is something that they very much welcome, and what they've been particularly keen to ensure that we don't have a team of you know, a support team that impose their activity onto care homes, and that's why it's to be a drawdown responsive resource. So they are very keen that they and we are seen as equal partners around the table together. And that we're not just another element of scrutiny like the Care Inspectorate. So, so part of the detail and the wording of the letter from the Scottish Government really tried to make that distinction. So the kind of old regime of what we were doing was oversight, and now actually it's about how we can not only work together within the NHS and all the different components that we have in supporting care homes, but how we can actually work together with the wider stakeholders. And certainly the discussions I've been having with the independent sector and their Scottish Care representatives have been positive.
Thanks, Gillian. We've also got questions from Anne and Louise, so if we could take you in that order.
Okay, so thanks very much for circulating the plan. Unfortunately, due to other commitments, I haven't had an opportunity to read it in detail, but there's obviously a very comprehensive set of activities set out there. So sorry if any of my questions are answered in that document. So I suppose two things. One, in terms of this shift that is expected and the actions that you've set out in your plan, of course I haven't been able to read it, how big a shift is that for us in terms of our you know, approach to life, that we've been following our own quality assurance processes and all that? Can you give me a sense as to whether we think we're well placed, or whether we've got a long journey ahead of us in achieving the expectations that have been set out for us? So that was one question. And the other one really was, I'm not sure, Gillian, I did flag this to you, but it may not be for you to answer. One of the things that really struck me about the Scottish Government ask, I suppose, in terms of moving to a much more collaborative, supportive approach, was that there didn't seem to be any suggestion that it would be useful to have the voice of residents and their families around the table when discussions are happening with providers. Now that may be because these discussions are are very technical and not focused around in a way that it would I'm not necessarily saying that people should be in attendance at the meeting, but I wondered if you could maybe say something about that. Might be inappropriate, but if it is, then how do we ensure that the voices of those stakeholders are front and centre in our other processes, such as our approach to quality assurance? Okay, thanks.
Do you want to respond to that, Gillian, before we hear from Louise?
add my.
If I may, thank you.
Pam.
Sorry.
Or Pam wants to come in.
No, I think you know, we're I think I might bring Donnell in as well, in terms of you know, we've got a strong record of support from registered services. We've been very good at engaging then around the oversight group. We're engaged with the care inspector, a number of other different partners. You know, it might be, you know, that we don't actually have the right people around the table in terms of that explicit engagement, but definitely through our networks and adult services, we are engaging with people around choice and around service development, so that's really important. I think what I would say is that we're a bit late to start with the recruitment, you know, in terms of getting the return back to the Scottish Government. So we really need to intensively engage and collaborate and get going with this, and that goes back to, you know, where we're waiting for permission for our submission to be agreed or not. It's a definite big shift from the care home oversight. So care home oversight was definitely in place to guide us and monitor us and support us through the pandemic, and to monitor and support and work in partnership with the independent care sector when they were facing challenges, particularly around bed closures, infection outbreaks, very, very sadly, deaths of residents, loss of income. So we're moving forward from that in terms of a more collaborative way of working, in terms of co-designing and co-producing as we go forward, in that spirit of how the collaborative elements are set out in the letter. So I'll stop there. I know that Louise wants to come in, because obviously there's professional issues as well in terms of engagement and leadership and things. So I will stop there and let others come in, conscious of time.
Yes, if we can maybe have Louise, Donnell, and Jerry's got his hand up as well, and then we'll need to move on. I'm conscious that just as the stand-in chair, I'm perhaps not quite as controlling things as well as Jerry would. So if we can have Louise, Donnell, and then Jerry, thanks.
Thanks, Philip, and you're doing a great job. Just to reference, as Pam has there is an ongoing and continued responsibility of the Nurse Director for care homes that's been agreed by the Scottish Government. So that was put in during the pandemic. That's not changing. So there is an expectation that we have that very much a part of that collaboration to make sure that the quality standards are everybody's business, really, because they should be, and patient experience, user experience should be all part of that too. And so I do absolutely think we need to work on how we do that better generally, as well as in the care home sector. But the one bit I just wanted to bring in and mention was the care home oversight group was a board-wide group that covered Argyll and Bute and Highland. And one of the things we've consciously done with this that is probably referenced in the paper, but just for clarity, is that this is a care home collaborative for Highland, and there's another care home collaborative for Argyll and Bute. We've separated out the two areas. The only cross work really is the public health role around infection control, because that does span, but this is to try and make it as local as possible, which will help with that local engagement with our communities and our colleagues in other partnerships as well.
Thanks, Louise. Donnell?
So it was just to say, in response to Anne's question, yes, I mean, personally, the residents of care homes are absolutely at the centre. And, I think everything we do, we need to be asking the question, how does, any new initiatives we're taking forward or any change in practice, how is this received? How, and we absolutely have at the heart of everything we do, the service users and their families, in helping us to